an unusual finding in a patient presenting for pulmonary thromboendarterectomy, pulmonary venous thrombosis. Pulmonary venous thrombosis, PVT, is a rare but potentially devastating disease state with a largely unknown incidence. In this issue of JCVA, the authors present a case of a 73-year-old woman with a past medical history of coronary artery disease status after coronary artery bypass grafting 6 years before presentation, hypertension, hyperlipidemia, and a remote history of cervical squamous cell carcinoma, presented with a recent diagnosis of bilateral pulmonary emboli and worsening functional status over the previous few months. A month before transferring to the author's hospital, she originally presented to an outside facility with acute versus chronic bilateral pulmonary emboli including thrombus in the bilateral distal main pulmonary arteries and bilateral segmental emboli. She was placed on anticoagulation at that time and eventually discharged home, only to again present it with worsening dyspnea at home. She then was transferred to the author's hospital for further workup. Her evaluation included a left heart catheterization demonstrating patent grafts and non-obstructive coronary disease. Right heart catheterization revealed a right atrial pressure of 10 mmHg, right ventricular pressure of 70-11 mmHg, and pulmonary arterial pressure of 70-23 mmHg. Pulmonary capillary wedge pressure was not obtained due to high thrombus burden in the bilateral pulmonary arteries. Transthoracic echocardiography showed normal left ventricular systolic function, a mildly dilated right ventricle with mildly depressed function, moderate tricuspid regurgitation, and severe pulmonary hypertension with an estimated right ventricular systolic pressure of 92 mmHg. Her chest CT revealed significant thrombus burden in the bilateral segmental pulmonary arteries, large bilateral pleural effusions, no significant parenchymal lung disease, a single 7 mm left upper lobe nodule, which appeared inflammatory, and no mention of pulmonary venous thrombosis. The CT images did not reveal the PVT and, thus, were not included. Perfusion scintigraphy was performed, indicating multiple areas of decreased perfusion and markedly decreased left lower lobe perfusion, indicating high likelihood for pulmonary embolism. The patient was hospitalized for further management. Systemic anticoagulation was transitioned from oral apixaban to an intravenous unfractionated heparin infusion. An aspiration thrombectomy was performed, with contents consistent with chronic thrombus, described as white-colored and scarred in appearance. Bilateral EchoFirst catheters were placed for tissue plasminogen activator infusion, which ultimately was unsuccessful at achieving thrombolysis. A presumed diagnosis of CTEPH was made, and the patient was brought to the operating room for pulmonary thromboendarterectomy. Once in the operating room, a pre-induction brachial arterial catheter was placed. Norepinephrine and vasopressin infusions were initiated preemptively, prior to induction. A stable intravenous anesthetic induction was accomplished with midazolam, etomidate, lidocaine, and rocuronium. Preemptive hemodynamic support was maintained with epinephrine and vasopressin boluses. Surface ultrasound before central venous catheter placement revealed occluded distal left internal jugular and innominate veins. Thus, the patent right internal jugular vein was cannulated with an 8.5-FR introducer catheter. TEE performed before central venous catheter placement also revealed neuroclusive superior vena cava thrombus. Thus, the guide wire was inserted to the minimal depth necessary to avoid thrombus dislodgement. A pulmonary artery catheter was not inserted due to thrombus burden and risk of further embolization. TEE examination revealed normal left ventricular (LV) function, a hypertrophic right ventricle (RV) with mildly depressed function, severe TR with a severely elevated right ventricular systolic pressure of 108 mmHg, mobile thrombus in the right atrium (RA) and right ventricle (RV), visible thrombus in the right pulmonary artery, RPA rig, and an unexpected finding of a thrombus in the left lower pulmonary vein near the bifurcation of the left upper pulmonary vein. The left pulmonary veins were visualized from the midesophageal position with the omniplane in the 90 to 120 degree range. Once the ligament of Marshall was visualized, the probe was retracted slightly and rotated toward the patient's left to reveal the bifurcation of the left pulmonary veins. The right pulmonary veins were visualized and appeared patent. The right upper and lower pulmonary veins were visualized from the midesophageal position at 90 and 50 degrees omniplane, respectively, with a rightward turn of the probe from the midesophageal bicaval view. The PVT finding was discussed with the surgeon at the time of discovery. An uneventful reduced sternotomy was performed. Upon entry into the mediastinum, several bulky lymph nodes were noted. Due to a high suspicion of malignancy in the setting of extensive vascular and intracardiac thrombus, lymph node biopsies were performed. Intraoperative pathology confirmed squamous cell carcinoma presumed to be metastatic disease. The procedure was aborted, and the patient was taken to the intensive care unit for recovery. The patient was extubated on postoperative day, POD 0. Final pathology on mediastinal lymph node biopsies confirmed metastatic cervical carcinoma. Oncology and palliative care consultants agreed that the patient was too deconditioned to undergo chemotherapeutic treatment in the perioperative period. She was discharged on POD 7 on warfarin with follow-up with her primary oncologist for future oncologic treatment options. The patient and her family elected for palliative care, and she passed away 3 weeks after discharge. This case highlighted the usefulness of intraoperative TEE and the importance of performing a full examination with interrogation of all 4 pulmonary veins, especially in patients with known thromboembolic disease.